I'm Tobias. I'm a second-year EM categorical resident here, and I'll be chatting with you guys about pulmonary ultrasound today. My main disclosure is just that I really like pulmonary ultrasound and ultrasound in general, but nobody's paying me to say anything. So the structure of my talk is as such. First, we'll go over indications for doing lung ultrasound, so when to get the pictures. Then we'll talk about interpreting them, or acquisition, so how to get the pictures, followed by interpretation, so what are we actually looking at? And then lastly, we'll talk about management, so how to, how to act on the information that you've obtained, and also the evidence for doing so. So the main indication that we're going to discuss today is undifferentiated shortness of breath. And it's important to note that often we're also going to be getting cardiac point-of-care ultrasound at the same time. And it's also important to give the disclaimer that there are metabolic causes of dyspnea. So it's important not to anchor on something structural wrong with the lungs or the heart. Pulmonary ultrasound is also indicated in trauma, either abdominal or thoracic, as part of the EFAST or by itself. We're not going to cover that in this lecture. And then if we have time, we'll talk briefly about airway management and confirming endotracheal tube placement with pulmonary ultrasound. So first, we'll talk briefly about the surface anatomy and what you're seeing when you put the ultrasound probe in different places. The main point here is just that the upper lobe of the lung is more anterior and the lower lobe is more posterior due to the oblique nature of the fissure. So just look at the images and think about what lobe you're looking at when you put the probe in different places on the body. There are sort of 6 main points that a fairly comprehensive lung ultrasound exam consists of, although our QPath worksheets only have room to put 4 in there. So if you're going to pick 4, we'll do R1, R3, and L1 and L3. R and L for right and left, and then the 1, 2, 3 indicating how superior it is. So R1 and L1 are going to be in the midclavicular line between the second and third ribs, roughly. And then what we see here is we're going to use a curvilinear probe. The probe marker should be pointing superiorly toward the patient's head. And you want to isolate a single intercostal space. So you may get more than that depending on the size of the person and the size of the probe, but you want to have one intercostal space centered with a rib shadow on the left and on the right of the screen, and the center of your screen with the lung parenchyma itself visible. So this is looking at R1, L1, which is sort of in the anterior chest, midclavicular line between some upper ribs. And then the second point that we'll talk about is called the PLAPS point, which is named both after the anatomic location and also what you're likely to see in this location. So it's the posterior/lateral alveolar/pleural syndrome point. So since this is the most dependent portion of the lung, you're looking at the base of the lung. The probe is placed laterally, again, probe marker up toward the patient's head. You're most likely to see a fluid collection or a consolidative process from fluid overload in this point, hence calling it the PLAPS point. And if you look at the images on the right of the screen, you can see exactly what we're looking at. So in the fan of the ultrasound beam on the left, we're going to see superior. On the right, we'll be seeing inferior. And so you can actually see lung itself, diaphragm as the sort of curved line, and then inferior to the diaphragm, you'll see on the right, the liver, on the left, the spleen. And it's important to note that sometimes what you see where you are seeing the lung parenchyma, or where you're seeing what the machine thinks it's seeing when you're looking at lung parenchyma, you're actually seeing various different kinds of artifacts. And so one of the most important points in this lecture is ultrasound beams do not go well through air. They scatter, they do not reflect in an organized fashion. And so if you're looking at air with an ultrasound beam, you're almost certainly seeing something that is not air, whether it's a consolidative process or edema, something that is more dense than air, or an artifact. And so 2 of the common artifacts that we see are, or I guess a sign and an artifact. The curtain sign, when somebody inspires a deep breath, the diaphragm flattens, and you see a curtain sweep over what you were looking at before. That is a well-aerated lung expanding and causing you to be blind to what you were formerly seeing on the ultrasound screen. Then The mirror image that you see on the right is from a mirror artifact. So the hyperechoic line of the diaphragm will cause a sort of reflection into the blank space, or the space that the ultrasound machine can't conceive of the lung parenchyma itself, the well-aerated lung parenchyma itself. And you're going to see essentially something that looks like liver. So it has the echo texture of liver where the lung actually is. We're going to talk about more interpretation now. So you can't talk about pulmonary ultrasound without talking about different kinds of lines and signs. And the A line is characteristic of a well-aerated lung. It is also an artifact. So when the ultrasound beams go down from the probe, they hit the pleural line, and then beneath the pleural line, there's nothing that they can really image well through. So they bounce back to the probe, and they bounce back to the pleural line, and they keep bouncing and bouncing. And so the ultrasound machine interprets distances based on the time that it takes for sound to reflect. And so you're going to see the same line evenly spaced, cast down horizontally, basically infinitely, as long as you are perpendicular to the plane of the pleura. So if you think about like holding a mirror in front of you and a mirror behind you, when the mirrors are like perfectly aligned, then you'll see almost infinite reverberation between the two of them. And I'm just using a lot of similes because it's kind of hard to conceive of the ultrasound physics without them. Next, we'll talk about lung sliding. So if the visceral and parietal pleura are well adhered to each other, if the lung is inflating and deflating normally, then you'll see a sort of shimmery white line, which is sometimes described as a line of ants marching back and forth. That is lung sliding, and that is typical of like a well-aerated lung with pleura that are sliding against each other. It is important to note that if you don't see lung sliding, it doesn't necessarily mean that you have a pneumothorax. It just means that you're not looking at the pleura slide against each other. So do you guys have any ideas for other things that might cause like a lack of lung sliding besides a pneumo? Louder. Pleurodesis, yeah. More? Potentially, yeah. Apnea also will cause it. So if you're not breathing, then the pleura are not sliding. If you're looking at the left chest and you've intubated someone and the tube is too far, then you may have a right mainstem intubation, so you're just not inflating and deflating the left lung. Pleural blebs or subpleural blebs can also cause this. So if somebody has a really bad case of emphysema and you're just looking at a section of the lung where there really isn't lung sliding against lung because you have a huge bleb, that can also cause this. So if you do not see lung sliding, you do not see the sort of shimmering, and that's what we're seeing on the right here. The most specific way to diagnose a pneumothorax with lung ultrasound is not an absence of lung sliding, it's actually a lung point. So a lung point identifies the exact place where you're seeing the pleura come apart from each other. So in the image on the left, we're looking, half of that image has lung sliding, and then half of the image does not have lung sliding. So on the right, you can see normal lung sliding. Let's see if this thing works. And you can see like the line of ants marching or the white line shimmering. Whereas on the left, you see essentially a barcode. And this is a lack of lung sliding. Lung points, you don't always see them, so the sensitivity is not great, but the specificity is approaching 100% for pneumothorax. Next, we'll talk about B lines and the spectrum of air to not air. So like we talked about, if you're looking at a lung that's just full of air, nothing else, just a normal healthy lung, well aerated, you shouldn't really see a whole lot besides A lines as long as your probe is orthogonal to the plane of the pleura. However, as the lung starts to fill with stuff, and it doesn't necessarily need to be fluid, it's not going to be like always cardiogenic pulmonary edema, although that's what we sort of tend to think of it as. This could also be from pulmonary fibrosis. You can see B lines in interstitial lung disease. But as the parenchyma of the lung starts to get denser, whether it's fibrotic tissue or fluid, then you'll start to see B lines. And B lines are perpendicular to A lines. They're vertical lines that obliterate the A lines, although you have to have the probe, again, perpendicular to the plane of the pleura to see them well. So if you're looking for B lines, first look for A lines, make sure that you're perpendicular, and the number of B lines corresponds loosely to the density of what you're looking at beneath them. Then all the way on the right, we're also going to talk about subpleural consolidation. So in a consolidative process like pneumonia, or hepatization, where the lung tissue takes on the appearance of liver or takes on the appearance of a solid organ. So again, there's a spectrum of B lines. On the left, we have sort of scant to moderate. Generally, when people are using lung ultrasound independently to diagnose acute decompensated heart failure or cardiogenic pulmonary edema, it's thought to be pathologic when there are 3 or more B lines in 2 or more lung fields bilaterally, although those definitions are kind of fuzzy. And I think, as with many things, provider gestalt is probably the way to go when you have gestalt as a provider. And then going to the right, you can see the B lines becoming confluent, which is where essentially like the lights from the disco ball are so numerous and plentiful that it's all light from the disco ball. There's no darkness at all. Moving forward toward even denser stuff, a subpleural consolidation, you can see over here, it's deep to the pleura, so it's not a pleural effusion, and you can see an anechoic or hypoechoic structure there, which is consolidated lung. And then, again, just another example of that here. So at the far end of the spectrum of like not air in the lung is hepatization. And this is distinct from the mirror artifact that we can see cast across the diaphragm. You're actually seeing static and dynamic air bronchograms here. So air bronchograms are essentially when you're looking at air in the airways, but the surrounding stuff is denser than air. So you're able to see the air trapped in the airways because there is all this denser stuff surrounding it. The denser stuff is consolidated lung tissue, alveoli with fluid or inflammatory stuff in it. And the air bronchograms are these hyperechoic patches there. So you can see in all of these images, you're going to have air bronchograms and a static air bronchogram. So an air bronchogram that moves only as the lung moves can be either from atelectasis or pneumonia, whereas a dynamic air bronchogram implies that the airway is not completely collapsed, and so this is more often seen in pneumonia. Next, we'll talk about pleural effusions, and so there's a kind of nautical theme to this slide. We have the jellyfish sign and the plankton sign, and it makes sense because we're talking about water where water should not be. So which view are we looking at in the image on the right here? Which point? Yeah, PLAPS. So this is at the base of the lung. We're looking at the interface between the diaphragm, liver, and then lung superiorly or to the left on this screen. You can actually see the spine where you shouldn't see the spine. So normally, ultrasound does not image well through air. You'll see the spine inferiorly, and then it'll sort of cut out above the level of the diaphragm. But if you're actually able to see the spine, it means that there's something other than air filling up the lung or the pleural space. So the spine sign is indicative of a pleural effusion. Then here we can actually see, whoop, this is not working anymore, but in the jellyfish sign, you can sort of see the quivering lung itself surrounded by the pleural effusion. And then the plankton sign is specific for exudative. So here we actually have like little particles of protein that are swimming around like plankton in the pleural effusion. So moving on to management. Again, it's important to realize that lung ultrasound is just one tool that we can use to evaluate a patient, and you have to interpret it as part of sort of a whole and a gestalt and your clinical exam history and other diagnostic tools. But for patients with acute undifferentiated dyspnea, there is some evidence that using ultrasound early can help speed up your time to a definitive diagnosis and thus treatment and dispo. And then you should also probably be looking at the heart when you do this. So there was a single study with about 100 patients where they were randomized to either early lung ultrasound or just regular workup and treatment, which consisted of chest X-ray and labs. And it was found that the patients who got an early lung ultrasound were received a definitive diagnosis in almost half of the time that patients who had the standard workup received it. This is just a single center study, or rather a single study with multiple centers in Iran. It's not necessarily generalizable to where we are, but it is some evidence that the earlier you do this, sort of the more like in your hands the diagnostic process is, because you're not relying on a radiology intern to read a chest X-ray, and you are in charge of the images that you're getting yourself. Also, important to note, this was specifically patients who had a kind of ambiguous diagnosis, so they didn't come in and like have, it wasn't like a slam dunk like heart failure exacerbation or COPD exacerbation, and actually a lot of patients were excluded from the study because they were thought to have too little diagnostic uncertainty. So this is for people who are kind of mysteries. And then there's also some evidence that lung ultrasound is more sensitive and more specific than chest X-ray in a vented ICU population for diagnosing both consolidative processes and pleural effusions. This is thought by me largely to be part of the issue with one view chest X-rays is that they're not fantastic and they're kind of a limited study. And so consider using lung ultrasound, especially in a population that can't stand up and like can't get a regular 2-view chest X-ray, or in the case of the downstate ER, you know, you don't want to send someone to the second floor, so consider just doing lung ultrasound. And this is, I believe, about 250 patients were included in this study, but all of my sources are at the end, and you can follow the links if you're curious. But you can see that the sensitivity and specificity are significantly greater of lung ultrasound, which is assessed by the gold standard of chest CT. And important to note also that the lung ultrasound in question consisted of 4 different points. So the R1, L1, and then the PLAPS point bilaterally. And going on to more evidence, there's a bunch of studies that look specifically at lung ultrasound for diagnosing acute decompensated heart failure. And these studies are mostly using the 3 or more B lines in 2 or more lung fields bilaterally data. And they're also judged against chest X-ray. These are cohort studies, so the patients actually receive both the lung ultrasound and chest X-ray, and then those are interpreted by blinded radiologists in most cases. And so in a study in, I believe, 2019, that pooled 6 different studies, it's a meta-analysis, including about 1,800 patients, they found that lung ultrasound had a greater sensitivity, but that the specificity was not significantly different from lung ultrasound to chest X-ray. But a subsequent study that included a couple more studies had about 1,000 more patients overall, found both an increase in sensitivity and specificity for lung ultrasound as opposed to chest X-ray. So moving on, we have a little moment or two for it. Can somebody tell me what we're looking at here in the images on the left and on the right? Just shout loud because the acoustics are bad. Exactly, yeah. So Dr. Solger said we have a normal intubation on the left and an esophageal intubation on the right. And so on the left, we see what's called sometimes the bullet sign, which is a single air mucosa interface, indicative that the tube is in the right place and the balloon is inflated correctly. And then on the right, we actually have 2 different air mucosa interfaces. So normally the esophagus is collapsed. We're not actually going to see an interface between mucosa and air. But if you intubate the esophagus and you inflate it with the balloon, then there will be one. And so there's a meta-analysis that looked at 17 studies with about 1,600 patients and found that using this technique where you put the linear probe, actually not the curvilinear probe, right above the sternal notch, was an extremely fast and sensitive and specific way to confirm endotracheal intubation, with a mean time to confirmation of 13 seconds and sensitivity and specificity above 97%. So last, I really like ultrasound in part because it gives you another chance to talk to your patients. you're stuck with them for a little bit. You get to show them what you're looking at. You get to involve them in their care, which sort of demystifies it to them a little bit, and it may humanize them a little bit to you. And if you guys want to participate in this, you can try to interpret the various images that we're looking at here. It's all just stuff that we talked about for the most part, with the exception of the bottom left image, which was, I think, someone actually trying to get an apical four-chamber view, and instead they're seeing all of this pleural effusion fluid. So yeah, what are we looking at on the top right? Yeah, hepatization, air bronchograms. And what about top middle or left? Yeah, subpleural consolidation. And what about bottom left? Or bottom right, rather? So yeah, I think this is a sort of septated pleural effusion. You can see the hyperechoic septa there. And then bottom middle is just a regular old lung with A lines. So in summary, for most pulmonary ultrasound, you use the curvilinear probe. You're going to look 2 or 3 points bilaterally, anterior, and then the PLAPS point. The lung is a spectrum of air to more dense stuff. And so everything you're looking at is either artifact that is representing air or something else that is representing consolidation. You should use this in undifferentiated dyspnea, but avoid anchoring bias and know that there are things that can cause shortness of breath that are not related to structural problems with the lungs or fluid overload or the heart. And then there's pretty good data suggesting that it can diagnose acute decompensated heart failure with greater specificity and sensitivity than chest X-ray, specifically and especially one-view chest X-ray. It's a good way to involve patients in their care, and it's operator dependent. So we're depending on you to become good operators and to practice this a lot. So thanks to the ultrasound team, mostly Chris Hannison for giving comments on my presentation, also to Jane Belyevskaya and Savi Alan, and to Dr. Hannah Reese for letting me practice the lecture on her. And here are the sources. Questions? Kelsey.